Large and medium vessels, vasculitides. General features. Vasculitides are a quite heterogeneous group of rheumatic immune-mediated disorders. They are inflammatory diseases affecting the blood vessels. Common findings are inflammatory leukocytes in vessel walls with reactive damage to mural structures, primary process versus secondary to another underlying disease, which leads to primary vasculitides are disorders primarily affecting vessels, while secondary vasculitides are the consequence of other systemic diseases such as rheumatoid arthritis and many others. Serious and sometimes fatal diseases they are. Sometimes they are simple and self-limited, but the majority of cases can cause severe illness and, if left untreated, they can lead to death. Symptomatic involvement of affected organs may either occur in isolation or in combination with multiple organs, so the manifestations are various. There is a significant difference in the clinical presentation if the affected vessels are small, for example capillaries in kidneys or lungs, or if they are large, like in the aorta. Another prototypical concept is that since vasculitis affects vessels and since vessels are everywhere in our body, different organs can be affected simultaneously or at different times. These diseases are therefore by definition systemic. For this reason, these diseases are by definition systemic. For these reasons, and mainly for their various possible presentations, their diagnosis is not so easy or straightforward. Moreover, therapy is not simple due to the fact that there are usually multisystemic diseases. The main pathological processes are loss of vessel integrity. So in small vessels, the inflammatory disruption of the vessel's wall causes small hemorrhages, like petechiae. In the aorta and other large vessels, this disruption causes wall thinning and weakness leading to aneurysm formation and, if not treated, aneurysm rupture and lethal hemorrhage. We can have also compromisation of the lumen, so tissue ischemia and necrosis, especially so for medium to large sized vessels. Inflammation inside the vessel wall will cause the wall to thicken, causing a reduction of the luminal space, leading to occlusion and stenosis, and thus downstream ischemia and necrosis. We have also systemic signs and symptoms of inflammation: fever, arthralgia, myalgia, and weight loss. So, signs and symptoms. Due to the systemic involvement and the potential to affect almost any body site, the signs and symptoms vary widely. However, there are some general symptoms that can suggest an underlying vasculitic process. They're all indicative of a systemic inflammatory state. So we can have fever, malaise, weight loss, arthralgia, myalgia, and generalized fatigue. The typical signs are purpura, which can be palpable or not palpable, but in disorders it is usually palpable. So we have small elevated skin lesions. We can have also skin vasculitis, which is an inflammation of the skin. We can have also monopolyneuritis multiplex. Polyneuritis is a symmetrical inflammation of the PNS, usually starting from the distal nerves and progressing proximally. The most common cause is diabetic neuropathy. Another example can be Guillain-Barré syndrome. Instead, polyneuritis multiplex means a non-symmetrical distribution of inflammation of different nerves in the body. Multiple single nerve inflammation. This is extremely typical of vasculitis due to the fact that there is inflammation of the perineurium, that is the little vessels that supply the nerve sheath. Can have also acute ischemic tubular necrosis and or rapidly progressive glomerulonephritis. We can have also abdominal pain, pulmonary infiltrates, sinusitis, otitis, and ischemic changes in tissues. Epidemiology and tests. The spectrum of these diseases includes any age from 20 to 80 years old. But there are also some diseases affecting young children. As in all autoimmune disorders, there is a female prevalence, although only slight, so 1.5 over 1 female to male ratio. There are a lot of non-specific but quite suggestive findings of systemic inflammation. You can have an increase in ESR, CRP, increase in PM polymorphonuclear cells, increase of platelets, eosinophilia more than 10%, but not present in all diseases. There can be a number of tests and markers associated to these conditions. You can have a rheumatoid factor, antinuclear antibodies. Typically, they show a non-specific pattern without the presence of anti-ENA and anti-DNA. Have anti-neutrophil cytoplasmic antibody, which is positive in some diseases. So the classification is, well, there was in the 90s, they did classification, including 7 diseases: panarteritis nodosa, Churg-Strauss syndrome, Wegener granulomatosis, hypersensitivity vasculitis, Enoch-Schonleigh purpura, giant cell arteritis, and Takayasu's arteritis. However, this is not extensive because it's a morphological classification. So there is a lot of overlap between different diagnoses and several other limits, such as not able to distinguish vasculitis versus other connective tissue diseases. They rely on a physician expert opinion, which is often the gold standard, so we have lack of objectivity. And many patients fulfill the criteria for more than one disease, for example, Wegener granulomatosis and Churg-Strauss syndrome. We have ANCA and angiographic findings are not included. Panarteritis nodosa is not differentiated from um, uh, from uh, um, from MAG, from MPA. A new set of classification criteria was published in the 94 in the Chapel Hill Consensus Conference based on pathologic criteria, classification according to the size of the affected vessel, MPA different from panarteritis nodosa, and ANCA. It was revised in the 2012, leading to the following classification that is used nowadays. It is based on the size of the affected vessels. So we can have a large vessel vasculitis, which is Takayas arteritis, and giant cell arteritis, also known as temporal arteritis or Orton's disease. Can have also medium vessel vasculitis, such as polyarteritis nodosa, and Kawasaki disease, and primary central nervous system vasculitis. You can also have small vessel vasculitis, so eosinophilic granulomatosis with polyangiitis, Churg-Strauss, also known as called Churg-Strauss syndromes, and allergic granulomatosis and angiitis. We have also granulomatosis with polyangiitis, also known as Wegener's disease, microscopic polyangiitis, uh, also known as microscopic polyangiitis or polyarteritis, Enoch-Schonleigh purpura, also termed IgA vasculitis, cryoglobulinemic vasculitis, also known as essential cryoglobulinemic vasculitis, hypersensitivity vasculitis, then vasculitis secondary to connective tissue disorders, like SLE, array relapsing polychondritis, or BC, and vasculitis secondary to viral infection, HBV, SCV, HIV, CMV, EBV, and Parvo B19. This division based on vessel size is very relevant because the main signs and symptoms change depending on the type of vessel affected. There can be either aneurysm formation or lumen occlusion. The clinical manifestations for the large vessels vasculitis are limb claudication, asymmetric blood pressure, absence of pulses, bruits, aortic dilation, renovascular hypertension. For the medium-sized vessel vasculitides, we can have cutaneous nodules, ulcers, livedo reticularis, digital gangrene, mononeuritis multiplex, microaneurysms, and renovascular hypertension. While for the small vessel vasculitides, we can have purpura, vesicobolus lesions, urticaria, glomerulonephritis, alveolar hemorrhage, cutaneous granulomas, sphincter hemorrhages, and uveitis, episcleritis, and scleritis. So, to repeat, in the large vessels, we can have large vessels aneurysm, which are usually asymptomatic until they have some complications, like rupture. We can have also organ claudication. Claudication is the ischemia of an organ or limb when its energetic demands increase. This occurs when a vessel is partially occluded. It is still patent enough to allow normal flow in conditions of rest, but as soon as the organ or limb demands increase, for example the GI tract after a meal or the legs when walking, the blood supply becomes inadequate and this results in tissue ischemia and pain. You can have also asymmetric blood pressure, for example with monolateral subclavian artery stenosis or aortic aneurysm. The measured pressures in the two limbs are different, so one can even be absent. You can have bruits. Stenotic arteries produce this characteristic sound at auscultation due to the resulting turbulent flow, and renovascular hypertension caused by stenosis of the renal artery. In the medium vessels, you can have ulcers. If the necrotizing process extends to the skin, livedo reticularis, which is very typical marble-like appearance of the skin, quite pathognomonic for medium-sized vessel involvement. And in the small vessels, we can have purpura and vesicobolus lesions, so skin involvement, and urticaria, which urticaria can be associated to vasculitis. To differentiate between vasculitic urticaria rash and allergic rash, it's necessary to biopsy the lesion and to check its duration, since the allergic one lasts for hours or days while urticaria lasts longer. Pathogenic mechanisms. They are significantly different among the three different vessel disease sizes, but there are also some significant overlaps. You can have immune complex formation deposition. So immune complexes are formed by antibodies bound to antigens, which can be either endogenous or exogenous. They can form, precipitate, fix complement, and damage vessels walls, creating inflammation. These are some diseases associated with immune complexes formation, such as Enoxone purpura, vasculitis in collagen vascular disease, serum sickness cutaneous vasculitides, and the HCV-HBV associated vasculitides. Can have also ANCA, anti-neutrophil and cytoplasmic antibody, which is mainly involved in small vessel vasculitides. Can have granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and MPA, which is microscopic polyangiitis. Can have also pathogenic T-cell response and granuloma formation. Both humoral and cellular immune responses are activated and cause damage. In some diseases, there might be a significant contribution of innate immunity as well, but the mechanisms are still unclear. So we have giant cell arteritis, Takayasu arteritis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. So, immune complex formation, HSP, vasculitis in collagen vascular disease, serum sickness, and SCV-SBV associated vasculitis. ANCA in GPA, AGPA, and MPA. T-cell response and granuloma formation in GCA. Takayasu granulomatosis with polyangiitis and eosinophilic granulomatosis with polyangiitis. Large vessel vasculitides. The main characteristic of large arteries is their thicker wall and the presence of vasa vasorum and nervae vasorum. The wall is formed by an adventitia, which is a tunica externa, a media, and an interna. The media is composed of myofibroblasts, that is smooth muscle cells. and between the media and the external there is a layer of elastic fibers that allows these vessels to accommodate pressure changes. The presence of nervi vasorum, and these vessels are innervated in fact, is another characteristic element of large arteries, which as a consequence, when affected by disease, produces pain. Pathogenesis. It is still unclear. Few things are known. We can have inflammation which starts from the vasa vasorum, so the inflammatory process begins from the adventitia, not from the lumen, which is mostly spared. This explains the absence of a thrombotic state in these diseases. The vasa vasorum endothelium instead is inflamed and it allows extravasation of leukocytes into the arterial wall. This process allows a massive reduction in lumen size in the absence of a thrombotic state. In giant cell arteritis, there is a late thrombotic state because the huge systemic inflammatory response can also activate the endothelium of the large vessels, but this is rare. So leukocytes extravasates from the inflamed vessels, which are not damaged, and release cytokines and chemokines attracting other leukocytes to the site, as well as acting in an autocrine way. It is the leukocyte as a receptor for the chemokines and cytokines it releases, thus sticking to that site and promoting continuous self-promoting inflammation. The level of organization of the inflamed tissue is extremely high, up to the point of lymphoid follicle formation. Then two symmetrical things can happen. Can have leukocytes start production of metalloproteases and reactive oxygen intermediates, which actively damage the matrix, losing the vessel's elastic integrity and its collagen structure, causing dilation and aneurysm formation. Can have increased production of um, PDGF or VEGF or other general growth factors, which act on myofibroblasts within the vessel wall, which start proliferating, causing media thickening and progressive stenosis of the lumen up to occlusion. These two mechanisms can coexist, but depending on the balance between lytic enzymes and growth factors, the result will be either stenosis or aneurysm of the vessel. Clearly, in the chronically inflamed wall, there would be a macrophage infiltrate as well as a polymorphonuclear cells and also granulomas. So typical microscopic findings are of follicles, granulomas, and inflammatory infiltrate. The major cytokines released are interferon gamma, IL-1, and IL-6, causing the general features of inflammation. Giant cell arteritis is a large vessel vasculitis, also known as temporal arteritis or Orton's disease. It's the most common vasculitis of the elderly more than 50 years. Almost no one younger than 50 years old can be diagnosed with giant cell arteritis. And this is one of the major diagnostic criteria, so nobody less than 50 years. And most common vasculitis of the elderly. The global prevalence in the population of more than 50 years old is of 200 over 100,000, meaning that it's an uncommon disease, although in the population of more than 80 years old it becomes more significant. And it represents around 1% of fever of unknown origins in patients aged more than 70 years old. There is a female prevalence of 3 to 1 in the Scandinavian population. Giant cell arteritis. In the Scandinavian population, giant cell arteritis is as common as in Latinos. It is exceptionally rare in Africans. The affected vessels are mainly large, medium-sized arteries, muscular, originating from the arch of the aorta. They must have lamina elastica and vasa vasorum. So this disease can't be present within the CNS because every artery that enters the dura mater loses the lamina elastica and vasa vasorum. It is extremely evident in the internal carotid artery. It is completely inflamed and damaged until it abruptly becomes normal upon entrance in the skull. This finding highlights the importance of these two structures in the pathogenesis of giant cell arteritis, although the mechanisms are still unclear and known. Moreover, it's an important element in differential diagnosis with other diseases in which intracerebral arteries are involved. The ophthalmic artery is an intracranial tract in which it is paired, but as soon as it exits from the meninges, it has lamina elastica and vasa vasorum again, so it is affected by the disease. The biopsy shows granulomatous, foreign body-like reactions inside the vessel walls. Another typical feature is that they are skip lesions. Thus, the diagnosis can be problematic since a biopsy may show a perfectly normal vessel if it is taken in between lesions. Signs and symptoms are headache. To differentiate headache associated with genital cell arteritis from that associated with other conditions, the main characteristic is a new onset at an age of more than 50 years old in a patient who never suffered from headaches. Can have jaw claudication with an onset of significant pain in the jaw while eating, remitting if resting for some moments, but restarting soon after the patients begin again to chew. Can have also polymyalgia rheumatica, which is a complex syndrome which will be explained more extensively later on. Can have also fever, which is however not so common. However, in the elderly, genital cell arteritis is one of the main causes of fever of unknown origin, and it is important to consider it because the aorta may be affected. In the absence of temporal artery involvement, aortic inflammation can be detected by PET scan. You can have also an abnormal temporal artery, which is prominent, pulseless, ardent palpation, which is rope-like, rigid. Be careful, many people have prominent temporal arteries, but only few have giant cell arteritis. The distinction can be made through the characteristic consistency of the artery and the lack of pulse. You can have also ocular involvement, which is extremely important to consider giant cell arteritis, the ophthalmic artery, because it can cause blindness if left untreated. We can have irreversible blindness, which is partial, complete up to 15%, optic nerve ischemia, ophthalmic posterior ciliary artery arteritis. It may be the first symptom of giant cell arteritis. There is a significant risk, around 50%, of contralateral blindness in 7-14 days if proper treatment, that is high doses of corticosteroids, is not applied immediately. You can have diplopia or ptosis, which is an arteritis affecting vasa nervorum. So cranial, for example, cranial nerve 7 and or cranial nerve 3rd, mononeuritis multiplex. Can have claudication, mainly of masticatory muscles, like jaw claudication, tongue, and swallowing. Upper limbs, when the aortic arch is involved, thus affecting the subclavian arteries. So, where we can have Raynaud's phenomenon, primary Raynaud's typically affect young females less than 20 years old. Instead, secondary Raynaud's is triggered by subclavian stenosis. Inflammatory aneurysms of thoracic aorta can also be present, with a relative risk of 17% that of the general population, 17 times more than that of the general population. We can have also rare neurological manifestations, but anyway, inflammation can spread to endothelium and cause thrombosis, thus leading to thromboembolic stroke. Can have myocardial infarction with coronary arteries involvement. Can have necrosis with complete occlusion of an artery in the absence of collaterals. Can cause necrosis of the downstream area. Laboratory findings are increased acute phase inflammatory indexes, such as ESR in the range of 100 mm per hour. A normal ESR is in the range of 520 mm per hour. With a good inflammatory process, it reaches levels around 50 mm per hour. With values around 100 or more, large vessel vasculitides are extremely probable. So, we can have also CRP and fibrinogen. At biopsy, usually done on the temporal artery, making sure there is sufficient collateral supply to avoid tissue necrosis. Ideally, should be done in all patients. Ideally, within 24 hours of steroids. Steroids alter the morphology of the lesion, making the biopsy useless, in fact. However, therapy must not be delayed, especially if there are visual problems. Can have also high false negative rate due to skip lesions nature of the disease. Can have role of ultrasound. There are some studies showing a role of ultrasound in identifying inflamed areas of temporal arteries to decrease the number of FN station of febrile neutropenia. No. Anyway, classification criteria. If at least three are met, the patient should be classified as giant cell arteritis patient. So, we have age of onset more or equal 50 years, new age, temporal artery abnormality, elevated erythrocyte sedimentation rate, and abnormal findings on biopsy of temporal artery. So, summary: when to suspect giant cell arteritis? When the patient is more than 50 years, so the older the patient, the higher the probability of a diagnosis of giant cell arteritis. When we have a new age, when we have visual loss, even transient, with an inflammatory reduction of the lumen, can give transient ischemia. We can have also polymyalgia rheumatica, fever of unknown origin, increased very high values of ESR, and other typical symptoms of giant cell arteritis. We can have also then polymyalgia rheumatica, which is an inflammatory condition of unknown origin. It can be a consequence of giant cell arteritis, but also be completely unrelated to it. It's a clinical syndrome which is extremely more frequent than giant cell arteritis. It's characterized by itching and stiffness of the shoulder, pelvic girdles, and the neck. The patients complain of an inability to perform simple and ordinary tasks like combing their hair and standing up because of intense joint pain. This is an important differential element. Many diseases present with decreased ability to perform these kinds of tasks, but they are usually painless. The neck pain could radiate and mimic an occipital migraine. It occurs in people more than 50 years old and usually does not respond to NSAIDs, but responds quickly and completely to low doses of steroids. It is related to giant cell arteritis with biopsy-proven GCA in about 421% of patients. Epidemiology. We have one case for every 133 people every 50 years of age. Incidence increases with age. Peaks at 76, 80 years. Females are more affected than males in all age groups with a ratio of 2 to 1. We have an higher incidence at higher latitudes, like in Scandinavian countries. It's rarely reported in blacks, but appears to have the same presentation course and response to treatment. These data are very similar to those of giant cell arteritis, but with higher prevalence. Diagnostic criteria. Criteria are morning stiffness, duration more than 45 minutes, hip pain or limited range of motion, absence of rheumatoid factor or ACPA, absence of other joint pain, and ultrasound criteria, which are at least one shoulder with subdeltoid bursitis and or biceps, tenosynovitis and or glenohumeral synovitis, either posterior or axillary, and at least one hip with synovitis and or trochanteric bursitis. Both shoulders with subdeltoid bursitis, biceps tenosynovitis or glenohumeral synovitis. Criteria most frequently used for diagnostic purposes, however, are empirical. Those of Under at Mayo Clinic and Early at Mason Clinic are the most widely used. Etiology. Genetic component is probable. there is no single factor that is necessary nor sufficient as has been found. There are only some associations. So HLA-DRB1 04 and DRB1 appear to be most associated with susceptibility to polymyalgia rheumatica. Genetic polymorphisms of additional genes involved in initiation and regulation of inflammatory reaction are in ICAM1, TNF, IL-1 receptor antagonists can have possible subclinical vasculitis. Clinical manifestations are persistent pain for at least 1 month, so itching and morning stiffness in neck, shoulder, and pelvic girdles lasting 30 minutes. Discomfort is bilateral, worse with movement, and usually interferes with activities of daily living. Inflammatory pain is not pain at rest, it's elicited by movement. If a movement is continued for a certain time, pain progressively decreases, but it's anyway the initial movement that elicited it. Can have evidence of systemic involvement, so inflammation. Shoulder pain is the presenting sign in 70-95% of patients. Hips and neck are involved in 50-70% of cases. Pain usually radiates distally towards elbows and knees. Systemic signs seen in 1/3 of patients who have fever, malaise, fatigue, anorexia, and weight loss. Exam reveals little evidence of proximal joint swelling or tenderness. MRI studies have shown subdeltoid and subacromial bursitis are more prominent than actual joint synovitis. Distal manifestations are also seen in one half of cases. We can have non-erosive, self-limiting, asymmetric peripheral arthritis in the knee and wrists, carpal tunnel syndrome, distal extremity swelling and pitting edema over dorsum of hands and wrists, ankles and feet. So distal manifestations. Laboratory findings are ESR more than 40 millimeters per hour, CRP is less influenced by other factors, may be more sensitive and a direct measure. We can have fibrinogen increase, we can have IL-6 increase, we can have a modest anemia of chronic disease in 2/3 of patients, we can have mildly abnormal liver function tests in 1/3, especially gamma GTs. This is probably a result of the general inflammatory state. Rheumatoid factor and antinuclear antibodies are usually negative. They may be positive, but not because of the disease. For example, 30% of elderly women have positive antinuclear antibodies. Muscle enzymes are normal, so this is extremely important for differentiation from myositis together with pain. The differential diagnosis is done with polymyositis, symmetrical proximal muscle weakness, pain not prominent, elevated CK, aldolase abnormal EMG, myositis of muscle biopsy. With fibromyalgia, late onset spondyloarthropathy, lack of adequate response to prednisone and presence of atypical features should make one consider this. Malignancy, either solid, kidney, ovary, stomach, or hematologic. Myeloma, primary amyloidosis, or infection, so bacterial endocarditis. Treatment and course. Corticosteroids are the drug of choice, 10-20 milligrams per day. Complete or nearly complete resolution of symptoms is seen in a few days, so absence of improvement should cause one to question diagnosis. Relapses do occur, more frequent in the first 1-2 years. We have to follow ESR, CRP, and fibrinogen. Treatment for 1 or 2 years is often required, sometimes even longer, at least 6 months. Always watch for corticosteroids adverse effects. So, in summary, polymyalgia rheumatica is a common illness in certain populations. We can have incidence which increases after the age of 50 and peaks between 70 and 80 years of age. Biopsy-proven giant cell arteritis had been observed in 40-21% of patients with polymyalgia rheumatica, so a diagnosis of polymyalgia rheumatica in the absence of giant cell arteritis should prompt careful investigation and follow-up for this disease. Can have arthroscopic, radioisotopic, and MRI studies indicate presence of synovitis in proximal joints and periarticular structures. Distal manifestations are present in about half of the cases. About 70-20% have normal ESR at diagnosis. A course of treatment of 1-2 years is often required, with some patients having a more chronic relapsing course. Overall mortality is not affected if not associated to GCA. Takayasu arteritis. It's a large vessel vasculitis named after the ophthalmologist Takayasu, who described a peculiar circular anastomosis in the fundus oculis of a patient with this arteritis. Epidemiology: it's present in young women at 40 years old. Females are much more affected than males in a ratio of 9/1. We have an higher incidence in Eastern populations, so Japan, China, India, and Central America. In Western countries, 2.6 cases per million per year, frequently under or misdiagnosed. Etiology is unknown. Anyway, we have association with LAB W52, B39.2, only in Japan anyway. Morphology. We have a granulomatous inflammation of the arterial wall of the aorta and its main branches. We have a segmentary involvement, so stenosis, aneurysms, no involvement of endothelium, so thrombosis is extremely rare, almost never present. Can have also subclavian arteries, which are almost always involved. In fact, it's a pulseless disease. Pulmonary artery involvement is present in about 20% of patients. The objective signs and symptoms are cyanosis, so-called extremities, vascular breaths, so renal artery stenosis, breaths heard in the posterior costophrenic angle, hypertension, which is renovascular. Its detection may be a problem because peripheral blood pressure is low due to stenosis of arteries despite very high central blood pressure. Thus it's frequently underestimated. Heights may be more representative, but also iliac arteries can be stenotic. You can have differences in blood pressure, left versus right, absent peripheral pulses, limb claudication, headache, stroke, syncope, dizziness, visual disturbances, angina pectoris, heart failure, angina abdominis, dyspnea caused by general hypertensive ischemic tubular necrosis caused by general HTN, and arterial pain, that is carotodynia. In this case, you see a complete occlusion of both vertebral arteries and both internal carotid arteries. The brain is supplied in this case by a collateral arrow of the first intercostal artery, which enters the external carotid, inverts the flow, reaches the common, and enters the internal carotid, supplying the whole brain thanks to a perfect Willis circles. Neck flexion caused the compression of this artery, leading to decreased oxygen supply to the brain. So we have the classification criteria, and 3/5 are necessary for diagnosis. Age less than 40, limb claudication, radial pulse, blood pressure differences of more than 10 millimeters per of mercury, vascular breaths, subclavian aorta, angiographic changes. Active disease at new or worsening, at least two, are signs or symptoms of vascular inflammation or ischemia, so claudication, diminished absent pulses, blood pressure asymmetry, breaths, carotidynia, increased ESR more than 20 millimeters per hour, angiographic abnormalities, systemic symptoms not attributable to other diseases, so fever, polyarthralgia, myalgia. Remission, so complete resolution, stabilization of all clinical manifestations, stable vascular lesions, so angiography. Treatments are high doses of corticosteroids, immunosuppressants, methotrexate, azathioprine, STX, and others. Biologicals are anti-TNF-alpha, IL-6, anti-stenotic measures. It's essential not to use stents since they induce inflammation, which, on top of an inflammatory disease, cause immediate relapse. So we can do percutaneous angioplasty or surgery, bypass graft or aneurysmectomy. Then we have medium-sized vessel vasculitides, like polyarteritis nodosa, which is a small and medium-sized vessel vasculitis, so arterioles, capillaries, and venues are spared. It's defined as a necrotizing inflammation of small and medium-sized arteries without arteriolar, capillary, and venular vasculitis, and without glomerulonephritis. It's a rare disease with a slight female prevalence, highly associated to HBV infection, so immune complex mediated. Symptomatic pathology description is involvement of medium small arteries, branching often involved, focal and segmental involvement, necrotizing vasculitis, so vessel wall fibrinoid necrosis, wall thickness arterial inflammation, and microaneurysms. Thrombosis also. In the early phase we have polymorphonuclear infiltration, so lysosomal enzymes plus reactive oxygen species. The chronic phase, we have macrophage infiltration that leads to fibrinoid necrosis with disruption of elastic and muscular layers. We have association to HBV infection in 20% of cases, more rarely HCV in 5% of cases. So manifestations are systemic symptoms like fever, malaise, and weight loss in 80% of cases, neuropathy, mononeuritis multiplex, polyneuropathy in 75% of cases, arthralgia or myalgia, cutaneous such as livedo reticularis, purpura, and ulcers, 50% of cases, renal disease, elevated creatinine, hematuria, aneurysm, and ischemia, not glomerulonephritis anyway, in 50% of cases. We have also GI symptoms, hypertension, respiratory manifestations, infiltrates, nodules, and cavities, CNS disease like stroke and confusion, orchitis such as testicular pain and swelling, which is extremely typical even if present only in 20% of cases. So, classification criteria. We need to have at least 3 criteria over 10. They have a low specificity. So they are otherwise unexplained weight loss greater than 4 kilograms, livedo reticularis, testicular pain or tenderness, myalgias, excluding that of the shoulder and deep girdle, weakness of muscles, tenderness of leg muscles, or polyneuropathy. The mononeuropathy or polyneuropathy, new onset diastolic blood pressure greater than 90 millimeters of mercury, elevated levels of serum blood urea nitrogen, more than 40 milligrams per deciliter or 14.3 millimoles per liter, or creatinine more than 1.5 milligrams per deciliter or 132 micromole per liter. Evidence of hepatitis B infection by serum antibody or antigen serology. Characteristic arteriographic abnormalities not resulting from non-inflammatory disease processes. A biopsy of small or medium-sized artery containing polymorphonuclear cells. And then we have Kawasaki disease, which is a mucocutaneous lymph node syndrome present in children aged 1 to 5 years, typically in winter, spring, so can be an infection trigger involved, more frequent in Japan away. We can have a possible superantigen activation of T cells. The diagnosis requires the presence of fever lasting at least 5 days without any other explanation, combined with at least 4 of the 5 following criteria: with bilateral bulbar conjunctival injection, oral mucous membrane changes including injected or fissured lips, injected pharynx or strawberry tongue, peripheral extremity changes including erythema of palms and soles, edema of hands or feet in the acute phase, and periungual desquamation in the convalescent phase. Can have also polymorphous rash, and cervical lymphadenopathy, at least one lymph node more than 1.5 cm in diameter. Other symptoms, completely aspecific, are diarrhea, vomiting, or abdominal pain in 61% of cases, irritability in 50% of cases, vomiting alone in 44% of cases, cough or rhinorrhea in 35% of cases, decreased intake in 37% of cases, weakness in 19%, and joint pain in 15% of cases. Pathology. Different from portal arteritis nodosa, here we have predilection for coronary arteries, CD8 positive T cell and macrophage infiltration, fibrinoid necrosis is absent. We can have tunica media disruption leading to aneurysms, cardiac involvement in acute phases in 20-30%, with coronary aneurysm formation in 5% of cases. So we have a high risk of coronary artery aneurysms, leading to a 1.15% mortality if underdiagnosed. At labs, we have an increased ENSR or NCRP, neutrophilic leukocytosis, thrombocytosis, aspirin and IVIG treatment, only case in which aspirin is indicated in children. The IVIG are useful both for the clearance of the possible viral trigger and act as immunosuppressants.